Welcome, curious minds and future microbial masters, to the deep dive. Today, we're not just dipping our toes into complex information, we're taking a real plunge into a hidden world. Imagine this realm teeming with microscopic organisms, some so incredibly particular about their living conditions, they're like, well, the divas of the microbial world, yet they possess the power to cause everything from a persistent nagging ear infection to life-threatening heart conditions that can seem to emerge out of nowhere.
It's a fascinating and sometimes scary world down there.
Absolutely. On the deep dive, our mission is simple, yet pretty profound. We take intricate scientific and medical information, we sift through every detail, and distill it down into clear, surprising, and hopefully truly actionable insights. Today, we're embarking on an essential journey, a true deep dive into the fascinating and, let's be honest, often challenging realm of specific fastidious and miscellaneous gram-negative bacteria. Our goal: to go as deep as we possibly can, to really master this information with the kind of precision and understanding you'd expect from elite professionals in the field. We want you to walk away feeling genuinely well-informed, ready to tackle these concepts with confidence.
Exactly. And our source material for this expedition, our map, if you will, is a comprehensive medical text, specifically Chapter 158, Infections due to the HACEK group and miscellaneous gram-negative bacteria. It's really packed with critical details on identifying these organisms, understanding the diverse diseases they cause, and gaining crucial insights into their diagnosis and, maybe most importantly, their treatment.
So, why does this particular deep dive matter to you? Well, whether you're a medical professional striving to stay, right at the cutting edge of infectious disease, or a curious learner expanding your understanding of microbiology, or maybe just someone who wants to grasp the unseen battles our bodies are constantly fighting, understanding these often overlooked pathogens is absolutely critical.
It really changes how we approach things.
It profoundly changes how we think about common ailments, how we recognize the subtle signs of severe conditions, and how we effectively combat the ever-present, ever-evolving threat of antimicrobial resistance. Get ready for some genuine aha moments, I think.
Definitely. There are quite a few in this chapter.
All right, let's kick things off with a familiar, yet as we'll see, increasingly complex foe, Moraxella catarrhalis. I mean, this bacterium has really evolved its game over the years.
It really has. It's a great starting point.
So when we're talking about identifying M. catarrhalis in the lab, what are the key characteristics? What are microbiologists looking for?
Well, there are a couple of pretty good visual clues. After about 48 hours of growth on the right media, its colonies actually take on this distinct pink color. It's quite noticeable.
Pink, okay. That's a neat visual identifier, a quick signal, right?
Yeah, exactly.
Yeah.
And it's also worth noting their size. These colonies tend to be generally larger than those of Neisseria, which M. catarrhalis might otherwise be confused with initially, just by looking at the plate.
Okay. So size and color give you a hint, but how do you definitively nail it down? Distinguish it from Neisseria for sure.
Right, you need more than just visuals. To definitively distinguish M. catarrhalis from Neisseria and other similar bacteria, laboratories rely on a variety of biochemical tests. There are actually many commercially available kits now that leverage these specific biochemical reactions. They make identification much more efficient and accurate in a clinical setting.
And that precision is vital, I assume, because mistaking it could lead to the wrong treatment.
Absolutely vital. As we're about to see, getting the ID right directly impacts treatment choices, especially considering its resistance profile.
And here's where its evolution truly comes into play, something that's, well, particularly concerning for global health, isn't it? The real story with Moraxella isn't just how common it is, but how quickly it adapted.
That's the key point.
Back in the 1970s and 1980s, M. catarrhalis swiftly acquired vololactamases. Now remind us, vololactamase, like, what exactly?
Think of vololactamase as tiny molecular scissors that the bacterium develops. These scissors can snip apart many common antibiotics, specifically the vololactam antibiotics like penicillin and amoxicillin, rendering them completely useless against the bacteria.
Wow, molecular scissors. And what's happened since then? Did that acquisition just fade away?
Unfortunately, no. It became widespread incredibly quickly. And the antimicrobial susceptibility patterns, they've remained remarkably stable since then. What this means today is that more than 90%, let me repeat that, more than 90% of M. catarrhalis strains now produce this vololactamase.
Over 90%. So they're essentially resistant to common first-line antibiotics like amoxicillin just baked in now.
Pretty much, yes. It's the vast majority. This isn't just a small percentage. It has fundamentally changed how we have to treat infections potentially caused by it. It really set the stage for the broader antimicrobial crisis we face today.
That widespread lactamase production must profoundly impact treatment approaches, especially for common infections. What are the main infections we see M. catarrhalis causing?
It really does dictate the approach. When we look at the common infections, there are two primary culprits where M. catarrhalis is a major player: otitis media, middle ear infections, mostly in children,
Right, very common.
and exacerbations of chronic obstructive pulmonary disease, or COPD, in adults. Those acute worsenings of lung disease are often triggered by bacterial infections, and M. catarrhalis is frequently involved. Both are incredibly common conditions.
Okay, so let's put ourselves in the clinic. If I'm a doctor, maybe in a busy practice, and I suspect M. catarrhalis is causing, say, a child's ear infection, but I don't have definitive lab results back yet, which often happens, what's my first line of defense? How do I choose an antibiotic empirically, to cover the basis?
That's a crucial question, and it really speaks to the reality of clinical practice.
Yeah.
Empirically, meaning before you have those definitive lab results, clinicians typically use antimicrobial agents that are active against the three most likely bacterial suspects in these scenarios: Streptococcus pneumonia,
Strep pneumo,
Haemophilus influenza,
H flu.
and of course, M. catarrhalis. It's a broad spectrum approach designed to cover the most probable pathogens effectively while you wait for more information, if you even get it.
Makes sense. Cover the big three. Now, thinking about the agents that have historically been effective against M. catarrhalis, the ones that can get past that lactamase shield, what have been our go-to options?
Historically, yeah, M. catarrhalis strains have generally remained susceptible to a range of agents beyond simple amoxicillin. These include amoxicillin combined with clavulanic acid. The clavulanic acid is a lactamase inhibitor. It protects the amoxicillin from those scissors.
Ah, the combo drug, like Augmentin.
Exactly. We also use extended spectrum cephalosporins, newer macrolides like azithromycin and clarithromycin, trimethoprim sulfamethoxazole, and fluoroquinolones. These have, for a long time, been pretty reliable choices, giving us good therapeutic options.
I sense a but coming. Here's where we see the relentless nature of microbial adaptation again, and it sounds like a concerning trend for global health.
There is a but, unfortunately. While those agents have generally been effective, recent reports, particularly from several centers across Asia, are showing substantial and worryingly increasing resistance to both macrolides and fluoroquinolones.
Wow, so even the backups are starting to falter.
It seems so in some regions. This isn't just a blip. It's a clear signal that our once reliable backup drugs might be losing their effectiveness against M. catarrhalis. It really changes the landscape of what we thought were stable, effective treatments and forces us to reevaluate our strategies, especially regionally.
So what does this all mean for the global picture and, the future outlook if resistance is popping up even to those drugs?
It means vigilance is key. This emerging trend underscores a critical need for continued, really vigilant monitoring of global antimicrobial susceptibility patterns of M. catarrhalis. Without this ongoing surveillance, understanding which strains are resistant to what and where our ability to implement effective public health strategies, especially for managing common infections like otitis media and COPD exacerbations, could be severely compromised.
It truly sounds like a constant race against microbial adaptation.
It absolutely is. And Moraxella offers a stark and very common reminder of that race.
Okay, from the evolving challenges of Moraxella, let's venture deeper now into a realm of even more elusive organisms, the HACE group. Their very name kind of hints at their unique, demanding nature, doesn't it?
It does. HACEK. It stands for something, and it signals they're a bit different.
What makes this group so unique? Why are they so fascinating, especially from a diagnostic perspective, if we're aiming for that elite level of understanding?
Right. Well, the first key characteristic is their fastidious nature. When we say a bacterium is fastidious, it means it has very specific and demanding growth requirements. They're essentially the gourmet diners of the microbial world. They won't just grow on anything.
Picky eaters?
Okay. These are slow-growing, gram-negative bacteria, and crucially, they require an atmosphere enriched with carbon dioxide for optimal growth, often around 5–10% CO2. This isn't something you can just grow on any standard petri dish left out in the regular air.
That's a critical point, isn't it? Because it directly impacts diagnosis. If a lab isn't specifically looking for them or doesn't know to consider them, they could be missed entirely.
Easily missed. For instance, they do not grow on media routinely used for enteric bacteria, like MacConkey agar. MacConkey is a very common selective medium used in labs to grow gut bacteria. HACEK organisms just won't grow on it.
So does that imply a significant risk of underdiagnosis in routine testing if the clinician doesn't specifically give the lab a heads up?
Absolutely. It critically emphasizes why alerting the microbiology laboratory when a HACEK organism is suspected is so vital. Without that heads up, the lab might just use standard culture methods that simply won't support their growth, leading to false negatives, delayed diagnoses, and potentially poor patient outcomes. It's a perfect example of why collaboration between clinicians and microbiologists is so important.
Good communication is key. Now, who's actually in this exclusive club? The HACEK acronym itself, for those who might not know, is a mnemonic. Can you break down the members for us?
Sure. The H stands for several Haemophilus species, most commonly Haemophilus parainfluenza. The A is for Achromobacter species. These were actually formerly known as Actinobacillus species, so the name changed.
Okay, Achromobacter, got it.
The C is for Cardiobacterium species, like Cardiobacterium hominis. The E is for Eichinella corrodens. This one's kind of known for its tendency to corrode or pit the agar surface as it grows.
Corrodes the agar, interesting.
And finally, the K is for Kingella kingae. Each one brings its own unique set of characteristics and clinical challenges to the table, and we'll definitely dive into those specific nuances as we go deeper.
It's quite a diverse little family there. Now let's talk about their natural habitat and the spectrum of infections they cause. Where do these fastidious organisms typically, hang out?
Typically, these HACE bacteria normally reside in the oral cavity, so their home base is right there in our mouths.
The mouth, okay, so logically they'd be associated with mouth infections.
Exactly. As you might expect, they're often associated with local infections in the mouth, things like dental issues, periodontitis, gum disease, or even abscesses around the teeth.
However, don't let that cozy oral habitat fool you, right? While they start locally, our source material makes it clear they have a significant capacity to cause severe systemic infections.
That's the critical point. They can escape the mouth. We're talking about serious conditions like bacteremia, the presence of bacteria in the bloodstream, and bacterial endocarditis.
Endocarditis, that's the infection of the heart's inner lining, often the valves. Life-threatening stuff.
Absolutely life-threatening. And this endocarditis can develop on either native heart valves, your original ones, or prosthetic valves like artificial heart valves someone might have had implanted during surgery. This really underscores their potential for widespread and serious impact.
Given that capacity for severe systemic infections, let's take a closer look now at that particularly serious complication, HACEK, endocarditis. This is where these sort of obscure organisms become acutely critical, isn't it?
Definitely. When we look at its prevalence and etiology, HACEK organisms are responsible for a notable chunk of infective endocarditis cases. In large studies, they contribute anywhere from about 0.8% up to 6% of all endocarditis cases.
Okay, 0.8 to 6%. That might sound small, but given how serious endocarditis is, that's actually a significant figure, right?
It's absolutely significant. Thousands of cases worldwide. And within that HACE group, which members are the most frequent culprits causing this endocarditis?
Yeah.
Does the risk vary much between the different letters in HACEK?
Good question. The most frequent culprits are Achromobacter species, various Haemophilus species, and Cardiobacterium hominis. Those three seem to be the most common players in HAC endocarditis.
And yes, the association, the risk of actually getting endocarditis if the bacteria gets into the bloodstream varies significantly by the specific organism. There was one really compelling study mentioned in the text.
Oh, yeah. What did it find?
It found that infective endocarditis was diagnosed in a remarkable 100% of patients who had Achromobacter actinomycetum combinans bacteremia.
Wow, 100%. So if that specific one gets in the blood, endocarditis is almost guaranteed in that study group. That's a truly striking correlation. That's the kind of specific detail an elite professional needs to know.
Exactly. Now, compare that. For Haemophilus parainfluenza bacteremia, the same study, 55% of patients developed infective endocarditis. Still very high, over half.
Still high, yeah.
But here's the stark contrast that highlights the nuances within the HACE group. In that same study, no patients, 0, with Eichinella bacteremia went on to develop endocarditis.
None at all. So even though Eichinella is in the group and can cause bacteremia, it didn't lead to endocarditis in that cohort. That's a key detail. It really drives home that you can't just lump them all together. The specific species matters hugely.
Precisely. Not all HACEK members carry the same endocarditis risk, even if they're found in the bloodstream. Understanding these nuances is crucial.
Okay, shifting to risk factors and clinical presentation. What kind of patient profile are we typically looking at for these invasive HACEK infections, especially endocarditis?
Typically, invasive HAC infection occurs in patients who already have a history of cardiac valvular disease. Maybe they have a known heart murmur or valve problem, or, importantly, patients who possess prosthetic heart valves.
So, individuals whose heart structures are already somehow compromised or altered, that provides the sort of foothold for these organisms.
Exactly. It provides a pre-existing vulnerability, a surface that's easier for these somewhat slow-growing fastidious organisms to colonize and then cause infection.
And what might trigger these infections? Are there specific events that often seem to precede a HACEK endocarditis diagnosis?
Often, yes. These infections frequently manifest in the setting of a recent dental procedure.
Ah, makes perfect sense given their oral habitat, like a cleaning or an extraction.
Could be anything, yeah.
Yeah.
A transient disruption to that oral barrier. They can also follow a nasopharyngeal infection, like a bad sinus infection or something similar. So, a seemingly minor procedure or an upper respiratory infection can inadvertently be the gateway for these bacteria to enter the bloodstream and reach the heart.
And once they reach the heart, which valves are most commonly affected?
The aortic and mitral valves are the ones most commonly affected. These are, of course, crucial valves for proper blood flow and function within the heart.
So, the typical clinical course for HACEK endocarditis is generally described as subacute. What exactly does that mean for the patient's experience? How does it usually present?
Subacute means it develops gradually over time, often quite insidiously. Patients might be feeling generally unwell for weeks or even months before a diagnosis is made. They might present with vague symptoms like a low-grade fever, fatigue, night sweats, maybe some weight loss, just generally feeling run down.
So, not necessarily dramatic, sudden onset.
Not usually, no.
Huh.
Particularly with Achromobacter or cardiobacterium infections. Their slow growth means the infection can kind of simmer for quite some time before it becomes clinically apparent or severe enough for the patient to seek serious medical attention.
But then there's Kingelia. You mentioned earlier it can be different. Our source highlights this contrast.
Right. That's where it gets really interesting. While the typical HACE course is subacute, Kingelia endocarditis might actually have a more aggressive, more acute presentation. This makes early detection potentially even more critical for Kingelia, as its clinical course might not follow that slow, simmering pattern we see with the others. It's an important exception to the rule.
Good point. Now, moving into unique manifestations and complications. The text mentions HACEK endocarditis tends to occur in younger patients compared with non-HACEK endocarditis. Is that right?
That's correct. The demographic is often younger than what we typically associate with endocarditis, which is generally considered more common in older adults. That's a significant observation.
And it's also more frequently linked to embolic, vascular, and immunologic manifestations. What does that mean?
It means these aren't just localized heart infections. They have a tendency to cause problems elsewhere in the body. Embolic refers to emboli, little clumps of bacteria and inflammatory cells called vegetations, breaking off from the infected heart valves and traveling through the bloodstream.
Where do they go? What kind of damage can they cause?
They can travel anywhere. If they go to the brain, they can cause a stroke. They can lodge in blood vessels of the limbs, the spleen, the kidneys, causing damage or infarcts there. Vascular manifestations might include inflammation of blood vessels, called vasculitis, and immunologic manifestations can occur as the body mounts an immune response, sometimes leading to things like kidney problems like glomerulonephritis or arthritis.
And that systemic embolization, those bits breaking off, is remarkably common with HACEK, isn't it? The numbers are quite high.
They are strikingly high. The prevalence ranges from 28% to as high as 71% in different studies. That's a huge proportion of patients experiencing this serious complication.
Wow. And on echocardiography, the ultrasound of the heart, those telltale valvular vegetations, the clumps themselves, are seen in up to 85% of patients.
Yes, echocardiography is very sensitive for detecting these vegetations in HACEK endocarditis, up to 85%. It's a key diagnostic tool.
And tying back to specific organisms and valve involvement, is there a pattern there? Do certain HACEK members prefer certain valves?
There seems to be a bit of a pattern, yes. Achromobacter and Haemophilus species seem to most often cause vegetations on the mitral valve. In contrast, Cardiobacterium is more distinctly associated with aortic valve vegetations.
Interesting. Those specific predilections could offer important clues during diagnosis, maybe helping clinicians narrow things down even before the cultures confirm the exact species, right? Another piece for that elite professionals toolkit.
Precisely. It's all part of building the clinical picture.
Okay, so unmasking these HACEK infections truly presents a diagnostic challenge, mainly because of that fastidious nature and slow growth we talked about.
Absolutely.
Which brings us back to the lab. You emphasize the importance of alerting the microbiologists if HACEK is on the differential diagnosis.
Critically important. It's not a standard request, so that clear, timely communication is absolutely key for them to set up the right conditions.
So when it comes to the culture systems and incubation times, how long does it usually take for these to grow, assuming the right conditions are met?
Well, the good news is, with improved culture systems, things like the automated bag tick system, most cultures that are going to yield a ACE organism will become positive within the first week. These automated systems continuously monitor for bacterial growth markers, like CO2 production, significantly speeding up detection compared to older manual methods.
So within a week, usually. That's better than I might have guessed for slow growers.
It is. The technology has improved. However, it's also really important to clarify a common misconception here. Some used to think you needed to incubate these blood cultures for a very long time, like 2 or 3 weeks, to catch HACEK.
Right, I've heard that. Hold the cultures longer.
But studies, according to our source, have not actually shown that this kind of prolonged incubation significantly increases the laboratory recovery of clinically significant HACEK isolates. So it seems to be more about having the right initial growth conditions, that CO2-enriched atmosphere, the right media, and using optimized detection systems rather than just waiting longer and longer.
Okay, that's good to know. Focus on the right setup, not just extended time. Now, as with many challenging pathogens, advanced molecular and mass spectrometry techniques are really changing the game, aren't they? Especially for these fastidious guys.
They absolutely are. They offer ways to bypass the challenges of slow growth.
Take polymerase chain reaction, PCR. How does that help us find these elusive bacteria faster?
Okay, think of PCR like a molecular photocopier. Even if there are only tiny fragments of a bacterium's unique DNA present in a sample like blood, or even a piece of heart valve tissue removed during surgery, PCR can find that specific DNA sequence and make millions or billions of copies.
Amplifying the signal, basically.
Exactly. We often target the 16S RNA gene, which is present in bacteria and has unique sequences for different species. This gene amplification allows us to detect the presence of a HAC organism directly from the clinical sample, often much faster than waiting for it to grow in culture. It's a huge advantage for rapid diagnosis, especially when time is critical in cases like endocarditis.
That's incredibly powerful. Faster diagnosis leads to faster, targeted treatment. And another technique mentioned is MALDI-TOF mass spectrometry. Sounds very high-tech. What is that, and how does it speed up identification once you do have growth?
MALDI-TOF MS is another game changer. Think of it as a super fast bacterial fingerprinting machine. Once you have a colony growing on an agar plate, even a small one, you can take a tiny sample, put it on a target plate, and the MALDI-TOF instrument uses a laser to vaporize the bacterial proteins. These proteins then fly through a vacuum tube, and based on how long they take to reach the detector, their time of flight, the instrument generates a unique mass spectrum, like a protein fingerprint.
A protein fingerprint.
Essentially, yes. The instrument software compares this fingerprint against a vast database of known bacterial fingerprints and can often identify the organism down to the species level within minutes.
Minutes, compared to traditional biochemical tests that could take days.
Exactly. It dramatically increases both the accuracy and the speed of diagnosis for HACEK infections once you have a colony. These cutting-edge methods, PCR for direct detection, MALDI-TOF for rapid identification from culture, are truly transforming our ability to identify these elusive organisms with the kind of speed and precision an elite professional would demand.
Oh, okay. Fantastic advancements. Now, let's shift gears slightly to a more optimistic note. The treatment and prognosis for HACEK endocarditis. While diagnosis can be challenging, the outlook, once identified, is actually remarkably positive, right?
Generally, yes. Compared to endocarditis caused by many other bacteria, especially other gram-negatives, the prognosis for HACEK is surprisingly good.
But even with treatment, there are some hurdles. Antimicrobial susceptibility testing for these organisms also presents its own difficulties, doesn't it? Echoing the growth issues.
It does. Again, because of their slow growth, obtaining timely and reliable susceptibility results can be tricky. This might delay the optimization of treatment if the initial empirical choice isn't quite right. Even detecting voltactamase production, Those molecular scissors might not be straightforward with standard, rapid methods used for faster-growing bacteria.
And where do we most commonly see resistance popping up among the HACE group?
Resistance, when it occurs, is most commonly noted in Haemophilus species and Achromobacter species. This makes accurate susceptibility testing for these particular members all the more vital.
Is there a preferred method for testing these slow growers?
To increase the accuracy of susceptibility testing, especially for determining the exact concentration of an antibiotic needed, E-test methodology is often employed. E-test uses a strip with a predefined gradient of antibiotic, allowing for a more precise reading of the minimum inhibitory concentration, or MIC. This helps clinicians tailor antibiotic therapy much more effectively than simpler disc diffusion methods might allow for these organisms.
Okay, so E-tests for more precision. When we look at the key therapeutic agents, what have recent studies shown to be most consistently effective against HACEK isolates overall?
That's the good news part. Recent studies, as cited in our source, have shown that both ceftriaxone, a powerful third-generation cephalosporin, and levofloxacin and fluoroquinolone have been consistently active against all HACEK isolates tested in those studies.
All isolates. That's excellent. It gives us reliable starting points for treatment, doesn't it?
It really does. Very reliable empirical choices in most cases.
Now, for a detailed treatment protocol, our source material references Table 158-1, which is invaluable for clinicians. What's considered the first-line therapy according to that table, and how effective is it generally?
Ceftriaxone, typically administered intravenously at a dose of 2 grams per day, is considered the first-line therapy for HA endocarditis, and it boasts a very favorable outcome rate, observed in 80% to 90% of cases.
80 to 90% success. That's a high success rate for a serious infection like endocarditis.
It is indeed. It's a very effective regimen.
And for patients who might not tolerate ceftriaxone, perhaps due to a severe allergy to lactams, what alternatives are available? And are there any caveats?
Right. For patients intolerant of lactam therapy, levofloxacin, usually at 750 milligrams per day, often intravenously initially, can be considered as an alternative. However, it's important to note, as the text points out, that the data supporting its use specifically for HACEK endocarditis are still somewhat limited compared to ceftriaxone, so it's generally considered a second-line choice for now.
And there's a crucial resistance note about Eikenella specifically, right?
Yes, absolutely crucial. The source material highlights that Eikenella corrodens is inherently resistant to several classes of antibiotics, including clindamycin, metronidazole, and aminoglycosides. This really underscores the absolute need for precise identification down to the species level and targeted therapy, because a broad-spectrum approach that might include those agents simply won't work for Eikenella.
Good point. Always need that specific ID. The duration of therapy is also clearly defined, which is important for managing patient expectations and ensuring eradication. How long are we typically talking for antibiotic treatment?
The duration is quite lengthy, reflecting the seriousness of endocarditis. For native valve endocarditis infection on the patient's original valves, it requires 4 weeks of antibiotics.
4 weeks.
But for prosthetic valve endocarditis infection on an artificial valve, it requires a longer course, 6 weeks. This is due to the increased complexity of treating infections involving foreign material and the higher risk of relapse if treatment is too short.
6 weeks for prosthetic valves. That's a significant commitment for the patient, but absolutely necessary for a cure, I imagine.
Absolutely necessary. The table also mentions other agents that could be considered, like ampicillin combined with sulbactam, another lactamase inhibitor strategy, or even penicillin or ampicillin alone, if, and this is a big if, the organism is definitively known to be susceptible through testing. But as we discussed, those testing challenges due to slow growth can sometimes complicate relying on penicillin or ampicillin.
Right, got to be sure about susceptibility. And there was a note about fluoroquinolones in younger patients.
Yes, specifically noted that fluoroquinolones, like levofloxacin, are generally not recommended for patients under 18 years of age due to potential concerns about side effects on growing cartilage, although they might be used in specific situations if benefits outweigh risks.
Okay, now let's talk about the remarkable prognosis for HACEK endocarditis. This is truly a bright spot, isn't it?
It really is, especially when you compare it to endocarditis caused by other types of bacteria.
The overall outlook for both native valve and prosthetic valve HACEK endocarditis is described as excellent. Significantly better, in fact, than the prognosis for endocarditis caused by non-ACEK pathogens. That's quite a powerful statement.
It is, and here's a critical distinction that really sets HACEK apart, especially concerning prosthetic valves. What's truly unique And frankly, quite amazing, is that unlike prosthetic valve endocarditis caused by many other gram-negative organisms which often require surgical intervention, like replacing the infected valve, in addition to antibiotics.
Which is major open heart surgery.
Exactly. HACEK endocarditis involving a prosthetic valve can often be cured with antibiotic treatment alone, frequently without the need for surgical intervention.
Wow. Okay, let's just pause and unpack that for a moment, because that's a hugely significant distinction. You're saying that for prosthetic valve endocarditis, a condition notoriously difficult to cure with just antibiotics when caused by other bugs, HACEK infections can often be cleared medically. That's remarkable.
It is remarkable. It's a testament to the general susceptibility of HACEK organisms to drugs like ceftriaxone and the effectiveness of these prolonged treatment protocols. It's a massive advantage for patients, potentially sparing them from the risks and recovery associated with major cardiac surgery. This positive impact of modern diagnostics and tailored treatment protocols for HACEK really stands out.
That really underscores the value of identifying it correctly and treating it appropriately. It translates into less invasive procedures, potentially shorter hospital stays overall, and vastly better outcomes for patients compared to other types of prosthetic valve endocarditis.
Precisely. And further solidifying this positive outlook, our source mentions a recent case control study. This study demonstrated that the one-year mortality rate for HACEK endocarditis was significantly lower than that for infective endocarditis caused by Viridin's group Streptococcus.
Viridin's strep, aren't those often considered a sort of less aggressive, more typically treatable form of endocarditis?
Generally, yes. So the fact that HACEK endocarditis has an even better one-year survival rate in this study is really quite telling. It shows that HACEK endocarditis, while undoubtedly serious and requiring expert care and prolonged therapy, has a surprisingly favorable prognosis when it's correctly identified and treated promptly with the right agents.
That's genuinely good news in a field often filled with difficult challenges. Okay, let's shine a spotlight now on some of the individual HACEK species, because as we've hinted, each one has its own unique clinical picture and impact. Mastering these differences is key. Starting with Haemophilus species, which one stands out most in HACEK endocarditis?
Within the Haemophilus genus, it's Haemophilus parainfluenzae that stands out. It's the most common Haemophilus species isolated from HACEK endocarditis cases. So it's the key player within that H subgroup for this specific condition.
And in patients with endocarditis caused by Haemophilus species, what's the typical presentation like? You mentioned maybe slightly more acute earlier. And what are common complications?
Right, compared to some others, it might be a bit quicker. About 60% of patients have been ill for less than 2 months before they present, suggesting a somewhat less insidious course than, say, Achromobacter. And a significant proportion, somewhere between 19% and 50%, depending on the study, develop congestive heart failure. That indicates a serious impact on cardiac function, which is a major and dangerous complication of endocarditis.
But what's truly encouraging are the mortality trends for Haemophilus endocarditis specifically. I understand there's been a dramatic improvement over time.
Indeed, it's a real success story. Older series, maybe from decades ago, reported alarmingly high mortality rates for Haemophilus endocarditis, sometimes as high as 30% to 50%.
Wow, almost half in some cases.
But more recent studies document a dramatic improvement. Current rates are now less than 5%. It's a huge drop, likely attributable to advancements in diagnostic tools, faster blood culture systems, maybe more use of echocardiography, coupled with more effective and timely antibiotic treatment protocols like using ceftriaxone.
That's fantastic progress. And beyond endocarditis, what other kinds of trouble can Haemophilus parainfluenzae cause? Is it just a heart valve bug?
Oh no, it's quite versatile as a pathogen. Beyond endocarditis, H. parainfluenzae has been isolated from a variety of other infections. These include meningitis, abscesses in the brain, dental areas, the pelvis, and the liver. It can also cause pneumonia, urinary tract infections, and septicemia, which is that severe bloodstream infection. So its clinical reach extends far beyond just the heart valves.
Okay, moving on to the A in HACEK. Achromobacter species. You mentioned these are actually the most common cause of HACEK endocarditis overall.
That's correct. While Haemophilus is common among its own kind, Achromobacter species, as a group, take the top spot for causing the most cases of HACEK endocarditis.
And which key species are we talking about here?
The main ones involved are Achromobacter actinomycetum comitans. That's the one with the 100% endocarditis rate in bacteremia from that study we mentioned.
Right, the memorable one.
Achromobacter aphrophilus, which again was formerly known as Haemophilus aphrophilus, and Achromobacter paraphrophilus. Those are the primary actors in Achromobacter-related HAC infections.
Is there anything specific that sets Aggregatibacter apart in terms of, say, valve involvement or maybe co-infections?
Yes, a couple of things. Notably, Aggregatibacter species are more often associated with prosthetic valve endocarditis than Haemophilus species are. So they're a particular concern for patients who have artificial heart valves.
Okay, more linked to prosthetic valves. Good to know.
And furthermore, A. actinomycetum comitans specifically can sometimes be isolated from soft tissue infections and abscesses, occasionally in association with another bacterium called Actinomyces israeli. This indicates a potential polymicrobial nature to some of its infections, meaning it might be working alongside other bacteria to cause disease.
What's the typical patient profile for Aggregatibacter endocarditis, and what does the clinical course usually look like? You hinted it might be more insidious.
Yes, the profile is quite specific, and the course is often insidious. Patients typically have a history of periodontal disease, like chronic gum infections, or have recently undergone dental procedures. This is especially true if they also have some underlying cardiac valvular damage. The disease itself develops very gradually, and patients may have been feeling unwell, subtly, for several months before finally receiving a diagnosis.
Several months. That must make early detection really challenging.
It really can. The symptoms can be vague for a long time, and common complications we see with Aggregatibacter endocarditis include those frequent embolic phenomena, bits breaking off and traveling, leading to things like strokes or organ damage in places like the spleen or kidneys. Congestive heart failure and renal problems are also common. So it's a pathogen that can cause widespread systemic damage if not caught and treated.
And there was a specific note about A. Aphrophilus causing other issues too.
Yes. A. Aphrophilus seems to have a particular knack for causing bone and joint infections, and it's also highlighted as an important cause of brain abscess. In one series mentioned, A. Aphrophilus was isolated from brain abscesses in a remarkable 10% of cases.
10% of brain abscesses? That seems disproportionately high compared to how common it is in the mouth.
Exactly. It's a rate that's disproportionate to its isolation from the normal oral flora. It suggests it has a particular ability to invade and cause infection in the brain. It can also cause abscesses in other organ systems, really showing its ability to spread far from its oral origins and cause serious deep-seated infections.
Okay, moving to C, Cardiobacterium species. Most often C. hominis, right? Though another species, C. valvarum, has also been implicated in endocarditis.
Correct. C. hominis is the main one. And like the others, these organisms primarily cause endocarditis in patients who already have underlying valvular heart disease or prosthetic valves.
And does Cardiobacterium have a preferred valve?
Yes, it seems to particularly favor the aortic valve. The aortic valve is the most frequently affected heart valve in Cardiobacterium endocarditis cases.
Many patients with Cardiobacterium endocarditis present with signs and symptoms suggesting a long-standing infection before they're diagnosed. What are some of those telltale signs that might point towards a chronic, widespread infection?
You might see evidence of arterial embolization, again, those bacterial clots traveling to arteries. Patients might present with vasculitis, inflammation of blood vessels, or cerebrovascular accidents, which are strokes. They might also show signs of immune complex glomerulonephritis, a type of kidney disease triggered by the immune response, or even arthritis at the time they present.
So signs well beyond just the heart itself.
Exactly. These are all systemic manifestations that point towards a chronic, smoldering, and widespread infectious process that's been going on for a while. And common complications seen with Cardiobacterium include, again, embolization, but also mycotic aneurysms.
Mycotic aneurysms, what are those?
Those are weakened, bulging areas in blood vessel walls caused by the infection seeding the vessel wall itself. They can occur in the brain or major arteries and are very dangerous because they can rupture. Congestive heart failure is also a common complication. These are serious systemic issues stemming from the cardiac infection.
Okay, now for E, Echinella corrodens. This one sounds fascinating because the text emphasizes it's most frequently recovered from infections in conjunction with other bacterial species. It's often part of a polymicrobial infection.
That's a key feature. It often doesn't work alone. It seems to be a collaborator in many infections.
And its clinical sources are incredibly diverse. Where does it pop up?
All over the place, really. It's famously found in human bite wounds, especially those clenched fist injuries that can happen during fights when a fist hits teeth.
Ouch. Okay.
But it's also found in endocarditis, soft tissue infections, osteomyelitis, bone infection, head and neck infections, respiratory infections, chorioamnionitis, an infection of the fetal membranes during pregnancy, Gynecologic infections, sometimes associated with intrauterine devices, IUDs, meningitis, brain abscesses, and visceral abscesses in internal organs. It really gets around the body.
Yet, despite its presence in so many different infection types, our source says Eikenella corrodens is actually the least common cause of HACEK endocarditis specifically.
That's correct. So, while it's definitely a member of the HAC group and can cause endocarditis, it doesn't contribute as heavily to the overall burden of HACEK endocarditis cases compared to its cousins like Achromobacter or Haemophilus.
Interesting. Okay, finally, within the HAS group, we have Kingellikingae. This organism has a dominant infection type that's especially noteworthy in children, right?
Yes, absolutely. More than half, over 50% of all K. kingae infections are bone and joint infections. This makes it a primary consideration, especially in pediatric osteomyelitis and septic arthritis.
So for kids with bone or joint infections, Kingella should be high on the list. What about the other infections it causes?
The majority of the remaining infections caused by K. kingae are infective endocarditis, bacteremia, just bacteria in the blood without a specific focus, and meningitis.
What's the typical association and transmission pattern for Kingellikingae, particularly in young children? How do they usually get it?
Invasive K. kingae infections that involve bacteremia are frequently associated with preceding or concurrent upper respiratory tract infections or stomatitis, which are sores in the mouth. This occurs in a high percentage of cases, around 80%.
80%. So a recent cold or mouth sores often precedes a serious Kingella infection.
It seems that way.
Yeah.
It strongly suggests that the oral cavity and the respiratory tract are common portals of entry for the bacteria to get into the bloodstream and cause systemic infection, especially in young kids.
And how common is it for kids to just carry this bacteria?
Oropharyngeal colonization rates, just carrying it in the throat without being sick, are highest in the first 3 years of life. It's detected in about 5% to 10% of children in that age group. And interestingly, the rates are even higher in children who regularly attend daycare.
Ah, daycare. Makes sense for transmission.
Exactly. It suggests easy spread in close contact environments like daycare centers. This colonization pattern perfectly coincides with the peak incidence of skeletal infections and other invasive infections caused by K. kingae, which occurs mainly between the ages of 6 months and 4 years.
So the time when kids are most likely to carry it is also when they're most likely to get sick from it. And it can spread between kids.
Yes, it can be transmitted from child to child and has even been responsible for outbreaks of invasive disease among young children in daycare settings, making it a significant public health concern in pediatrics.
Are there any particularly distinct clinical presentations for Kingella?
Yes. One distinct and potentially concerning presentation of K. kingae bacteremia is that it can present with a petechial rash. That's a rash of tiny red or purple spots caused by bleeding under the skin.
Petechiae. Doesn't it make you think of something else really serious?
Exactly. It can strikingly resemble the severe rash seen in Neisseria meningitis sepsis or meningococemia, which is a highly aggressive and often fatal infection. This resemblance makes rapid and accurate diagnosis absolutely critical to differentiate between these two serious conditions, as the treatment and urgency differ.
That's a crucial point for clinicians. How have diagnostic advancements helped us identify K. kingae more readily now? It used to be considered quite rare, didn't it?
It did. But diagnostic advancements have played a huge role in its increasingly common isolation. Improved microbiologic methodology in general helps, but specifically, molecular methods like real-time PCR have been instrumental. Also, a simple but effective technique is inoculating clinical specimens, like synovial fluid taken from an infected joint, directly into aerobic blood culture bottles instead of just standard culture tubes. This seems to enhance the recovery of K. kingae.
Using blood culture bottles for joint fluid. Interesting trick.
It works well for Kingella. Furthermore, PCR studies performed directly on blood or joint fluid can identify K. kingae, even in cases where the traditional cultures remain negative. This is huge for diagnosing culture-negative bone and joint infections in kids.
And here's where it gets truly surprising, maybe the biggest aha moment in this section, and frankly, a potential game changer for pediatric infectious disease. Many clinicians, even experienced ones, might find this genuinely shocking.
Yes.
Some studies, according to our source, suggest Kingellikingae has actually surpassed Staphylococcus aureus as the leading cause of septic arthritis and osteomyelitis in young children in some regions.
It is a profound shift, and yes, Quite surprising to many. For decades, Staph aureus was the undisputed king, the #1 cause of bacterial bone and joint infections in children. We were all taught that.
Right, Staph aureus was always the answer on the test. What does this shift tell us? If Shigella, this fastidious organism once considered rare, is now potentially the leader, what are the implications?
It tells us we absolutely must update our thinking, our diagnostic algorithms, and potentially our empirical treatment choices for septic arthritis and osteomyelitis in young children, especially those between 6 months and 4 years old. It means that relying solely on treatments targeting Staph aureus might miss the actual culprit more often than we thought.
So the empirical coverage we discussed earlier might need adjustment in this specific pediatric scenario.
Potentially, yes, depending on local epidemiology. It emphasizes that what we thought we knew, what was considered absolute dogma, can change dramatically with improved diagnostics and ongoing surveillance. It's a stark reminder that the microbial world is incredibly dynamic, and we, as medical professionals, aiming for that elite level of understanding, have to constantly adapt and stay vigilant.
An amazing example of evolving knowledge. Okay, moving beyond the well-defined HACEK group now, let's explore some other fastidious gram-negative bacteria. While perhaps less frequently discussed than HACEK or Moraxella, they're equally important for a truly comprehensive understanding of these microbial threats. We'll start with Capnocytophaga species.
Right, Capnocytophaga. Like the HACEK organisms we just discussed, these are also fastidious. They are fusiform, gram-negative cocobacilli, meaning they look like rods that are tapered at the ends. They are facultatively anaerobic, so they can grow with or without oxygen, but crucially, they also require an atmosphere enriched in carbon dioxide for optimal growth, just like HACEK. That CO2 requirement is key.
And many Capnocytophaga species, like C. ochracea, C. gingivalis, C. hemolytica, and C. sputagina, are actually part of our normal oral flora, right? So they're common residents in our mouths, again, just like the HAC group.
Exactly. They live there normally. And as a result, most infections they cause are contiguous with the oropharynx, meaning they're directly connected to or spread from the mouth and throat. We're talking about things like periodontal disease, respiratory tract infections, abscesses in the neck, cervical abscesses, and even endophthalmitis, which is a serious infection inside the eye, potentially spread via the bloodstream from an oral source.
But these organisms aren't just limited to local infections around the mouth, are they? They can cause more serious systemic problems.
Definitely. They have been associated with severe systemic infections, particularly sepsis, that life-threatening whole-body response to infection, especially in immunocompromised hosts. This is particularly true for neutropenic patients, those with very low white blood cell counts, often due to chemotherapy, who also have oral ulcerations or mucositis. The mouth sores provide an entry point.
Makes sense. Compromised host, compromised barrier. What else can they cause systemically?
Beyond sepsis, they can cause meningitis, endocarditis, though less common than HACEK, cellulitis, skin infection, osteomyelitis, bone infection, and septic arthritis, joint infection. Capnocytophaga species are often isolated from many different sites, frequently as part of a polymicrobial infection, meaning they're found alongside other bacterial species, all contributing to the problem.
And there's a concerning trend with Capnocytophaga regarding antibiotic resistance.
Yes, the text highlights a high prevalence of resistance to both lactams, like penicillin, and macrolides, like erythromycin or azithromycin, among these oral Capnocytophaga species. And interestingly, it suggests our own oral cavities, where many of these resistant species reside, actually serve as a reservoir for the resistance genes themselves.
Wow. So our mouths can be like a little library for resistance genes that these bacteria can potentially share.
That's one way to think about it, yes. It highlights how our individual microbiomes can contribute to the broader global issue of antimicrobial resistance. It's truly a complex ecosystem.
Now, it's also critical to distinguish between these oral Capnocytophaga species and those that have an animal origin, right? Specifically from dogs and cats.
Absolutely critical distinction.
Right.
Capnocytophaga canomorsus and Capnocytophaga synodegmi are endogenous to the mouths of dogs. Canomorsus means dog bite. And cats, cyno related to dogs.
So people get these from pets.
Yes. Patients infected with these species frequently have a history of a dog or cat bite, or even just exposure, without obvious scratches or bites like being licked on an open wound, or even on intact skin if the barrier is somehow compromised.
A simple lick could do it.
Potentially, yes, especially in vulnerable individuals. Certain predisposing conditions significantly increase the risk of developing severe life-threatening disease from these animal-associated Capnocytophaga species.
What conditions put people at higher risk?
The major ones are asplenia, meaning lacking a functional spleen, either surgically removed or non-functional due to disease.
The spleen is important for clearing these types of bacteria, right?
Technically important for clearing encapsulated bacteria from the blood, yes. Other risk factors include long-term glucocorticoid therapy, steroids, and heavy alcohol abuse or underlying liver disease. In these vulnerable patients, infection with C. canomorsus can lead to devastatingly severe sepsis with shock and disseminated intravascular coagulation, or DIC.
DIC, that's the dangerous bleeding and clotting disorder.
Yes, where tiny blood clots form throughout the body, consuming clotting factors and leading to uncontrolled bleeding elsewhere. Patients typically develop that petechial rash, the small pinpoint red spots, which can rapidly progress to purpuric lesions, larger purple patches, and even gangrene tissue death, often affecting the fingers, toes, nose. These are incredibly aggressive and dangerous infections with high mortality.
Scary stuff.
Oh.
So how do we treat Capnocytophaga infections, both the oral and the animal associated ones?
Okay, regarding treatment, referencing table 158, tab 1 again, for empirical treatment, especially if you suspect C. canomorsus from a dog bite in a high-risk patient, because of that increasing lactamase production, a penicillin derivative combined with a folate lactamase inhibitor is currently recommended. A common choice would be ampicillin sulbactam.
Okay, cover the potential resistance.
Exactly. Now, if the isolate is identified and known to be susceptible, particularly C. canomorsus, it should ideally be treated with plain penicillin, as it's usually very effective if there's no resistance. Capnocytophaga species are also generally susceptible to clindamycin and third-generation cephalosporins like ceftriaxone.
And what about prevention, especially for those high-risk asplenic patients?
Critically important point. Antibiotics should be given prophylactically, meaning preventatively, to asplenic patients who have sustained dog bite injuries.
Sure.
Given their extremely high risk for overwhelming sepsis from C. canomorsus, starting antibiotics immediately after a bite, even if it seems minor, can be life-saving. Early intervention is absolutely key to prevent catastrophic illness in this group.
Good advice. Okay, next on our list of fastidious gram-negatives is Pasteurella multocida. What's the story with this one?
Pasteurella multocida. This is another fastidious gram-negative coccobacillus short plump rods. It characteristically shows bipolar staining, meaning the ends of the rod stain darker than the middle, which can be a hint on a gram stain.
And its primary reservoir is also animals, right? Like Capnocytophaga canomorsus.
Yes, its main home is in animals. It colonizes the respiratory and gastrointestinal tracts of many domestic animals, with very high oropharyngeal colonization rates found in healthy pets, somewhere between 70% to 90% in cats, and 50% to 65% in dogs.
Wow, 70 to 90% of cats. So if you have pets, especially cats, you're very likely sharing your space with Pasteurella multocida, often without knowing it.
Very likely, yes. Transmission to humans primarily occurs through animal bites or scratches, just like C. canomorsus. However, Pasteurella can also spread via the respiratory tract, perhaps from contact with contaminated dust or infectious droplets from the animal, or even by deposition of the organism onto injured skin or mucous membranes during licking by the animal.
So again, a bite, a scratch, or even a lick on broken skin could transmit it.
Correct. Most human infections caused by Pasteurella multocida, almost 2/3 of them affect the skin and soft tissue. And the majority of these infections are caused by cats, probably due to the nature of cat bites, which are often deep puncture wounds.
Ah, so cat bites are particularly risky for Pasteurella. What does that infection typically look like?
It often presents as a rapidly developing cellulitis redness, swelling, warmth, and pain at the site of the bite or scratch, usually within 24 hours. It can progress quickly.
And can it cause more serious systemic problems?
Yes, especially in certain populations. Patients at the extremes of age, the very young or the elderly, or those with serious underlying disorders like cirrhosis, diabetes, or other forms of immunocompromise, are at increased risk for systemic manifestations beyond just the local wound infection.
What kind of systemic manifestations are we talking about?
They can be quite severe and diverse. They include meningitis, peritonitis, infection of the abdominal lining, osteomyelitis, and septic arthritis, especially if the bite was near a bone or joint, endocarditis, septic shock, and even severe skin manifestations like eczema, necrotizing fasciitis, that rapidly spreading flesh-eating infection, and purpura fulminans, another severe blood clotting disorder leading to skin necrosis.
Necrotizing fasciitis from a cat bite. That's terrifying.
It's rare, but it can happen. And interestingly, the text notes that these severe systemic cases are more likely to occur even without clear evidence of an animal bite, particularly in these vulnerable patient populations, though cases certainly occur in otherwise healthy individuals too, usually linked directly to a bite.
What about respiratory involvement?
Yes, if P. multocida is inhaled, Perhaps from close contact with an infected animal or contaminated environment, it can cause acute respiratory tract infection like pneumonia or bronchitis. This seems to be more common in patients who already have underlying sinus or pulmonary disease.
Okay, how do we treat Pasteurella multocida infections? Is it generally susceptible to antibiotics?
Generally, yes. As outlined in Table 158.1, Pasteurella multocida is typically susceptible to a broad range of commonly used antibiotics. This includes penicillin, ampicillin, the combination antipicillins and mobactam, second and third generation cephalosporins, tetracyclines like doxycycline, and fluoroquinolones. Penicillin is often considered the drug of choice if the strain is known to be susceptible.
So lots of options usually. Is resistance a major concern?
It's less of a concern than with some other organisms we've discussed, but it's not zero. The text does mention that now-collectemias of producing strains have been reported. Therefore, while penicillin is often effective, susceptibility testing is still important, especially for guiding therapy in severe infections or if the initial treatment isn't working as expected. Using something like ampicillin sulbactam empirically for a bite wound often makes sense to cover potential lactomase production.
Good practical advice. Okay, shifting gears now quite significantly. We're moving into a broader and highly diverse category, miscellaneous gram-negative bacteria. This sounds like a real grab bag of organisms.
It really is. This group is incredibly diverse, encompassing organisms found in all sorts of environments: soil, water, freshwater, saltwater, even tap water sometimes, and healthcare settings. It includes bacteria that don't neatly fit into other categories.
And there's a critical overarching note for this entire section, right? Something vital for treatment.
Absolutely vital. The source material stresses that treatment for all organisms discussed in this miscellaneous section should ideally be based on in vitro susceptibility testing. Why? Because multi-drug resistance is a common and unfortunately growing concern among many of these organisms. Table 168-2 in the text likely details some of this. Trying to treat these empirically without knowing the specific strain's resistance profile can be very risky.
So lab testing is paramount here. Got it. Let's start with Achromobacter xylosoxidans. What can you tell us about this one?
Achromobacter xylosoxidans. It's an aerobic, non-fermenting, gram-negative organism. It doesn't ferment sugars like many other bacteria do. It's probably part of our normal endogenous intestinal flora, living in our gut. But interestingly, it has also been isolated from a wide variety of environmental water sources, things like well water, contaminated intravenous fluids in hospitals, and even humidifiers.
So it's in us, and it's in the environment, particularly water. Who's most at risk for infection?
As with many opportunistic pathogens, immunocompromised hosts are at increased risk. This includes patients with cancer, those experiencing neutropenia after chemotherapy, individuals with cirrhosis or chronic renal failure, and importantly, patients with cystic fibrosis, where it can become a chronic respiratory colonizer and pathogen.
And it's been linked to hospital outbreaks.
Yes, Achromobacter xylosoxidans has been implicated in nosocomial outbreaks, hospital-acquired infections, and sometimes even pseudo-outbreaks, where contamination of lab equipment or fluids makes it seem like there's an outbreak when there isn't truly patient infection. These outbreaks have often been attributed to contaminated fluids. Actual clinical illness has been associated with isolates recovered from many body sites, including the bloodstream, often in the setting of intravascular devices like central lines.
What about community-acquired infections?
Community-acquired Achromobacter xylosoxidans bacteremia does occur, and it usually happens in the setting of pneumonia, suggesting that inhalation might be a route of infection from environmental sources in some cases.
Is there a unique symptom associated with it?
Yes, a unique and quite concerning symptom, which could be a diagnostic clue, is that metastatic skin lesions are reportedly present in about 1/5 of bacteremic cases. These are skin lesions that appear in locations distant from the primary infection site, indicating systemic spread of the bacteria through the bloodstream.
Metastatic skin lesions. Wow. And what about the overall prognosis?
The reported mortality rate for Achromobacter xylosoxidans infections, particularly bacteremia and pneumonia, is remarkably high. The text mentions rates up to 67%, which is a figure similar to the high mortality rate seen in other serious bacteremic gram-negative pneumonias. It underscores the significant clinical impact this organism can have, especially in vulnerable patients. Given that severity and the potential for resistance, what are the go-to treatments? For treatment, carbapenems, like meropenem or imipenem, tigecycline, and potentially colistin, are typically the agents most likely to show activity against Achromobacter xylosoxidans. However, again, susceptibility testing is absolutely paramount because resistance patterns can vary significantly, and multi-drug resistance is definitely a concern.
Okay, next up. Aeromonas species. What's the lowdown on these?
Aeromonas species. These are facultative anaerobic gram-negative bacteria. The infections we see are most often caused by species like Aeromonas, Hydrophila, hydrophila means water-loving, A. cavii, Averronii, and increasingly recognized Aedocarditis. And true to the name Hydrophila, these organisms proliferate widely in potable water, drinking water, freshwater sources like lakes and rivers and soil. So they're very much environmental pathogens we encounter quite regularly.
Is it true there's some debate about whether Aeromonas actually causes gastroenteritis, like traveler's diarrhea?
Yes, there's actually quite a bit of controversy surrounding that. The issue is that asymptomatic colonization of the intestinal tract with Aeromonas seems to occur frequently in healthy people. And importantly, no large, definitive, clonally related diarrheal outbreak has ever been clearly documented, which makes it hard to definitively prove causation for common diarrheal illness.
But it's not entirely benign in the gut.
Not entirely, no. There have been rare but documented cases of hemolytic uremic syndrome, HUS, that severe kidney complication usually associated with certain E. coli strains following bloody diarrhea where Aeromonas was implicated. This suggests it can play a role in severe diarrheal illness, at least in certain contexts or with certain strains, even if it's not a common cause of simple diarrhea.
Okay, beyond the gut, where else does Aeromonas cause problems?
It causes a range of infections, both healthcare associated and community acquired. It can cause healthcare associated sepsis and bacteremia, particularly in infants with multiple underlying medical problems, and also in immunocompromised adults, especially those with cancer or underlying hepatobiliary disease, including cirrhosis. Acavia seems particularly linked to healthcare related bacteremia.
And in the community.
Community-acquired infections include bacteremia, spontaneous bacterial peritonitis, infection of the abdominal fluid, often in patients with cirrhosis, biliary tract infections like cholecystitis, and importantly, various skin and soft tissue infections, especially related to water exposure.
Skin and soft tissue, like wound infections.
Yes, and sometimes very severe ones. Severe soft tissue infections, including necrotizing fasciitis, that rapidly spreading flesh-eating infection, are notably reported more commonly in places like Taiwan compared to Western countries. And perhaps most strikingly, Aeromonas was identified as the most common pathogen associated with skin and soft tissue infections after the devastating 2004 tsunami in Thailand.
The most common pathogen after the tsunami. Wow, that really highlights its link to water-related disasters.
Absolutely. It's strongly associated with floods and other hydrologic disasters, often found alongside other waterborne gram-negatives like Shewanella and Achromobacterium. Increased exposure to contaminated water during these events leads to infections.
Can it also infect trauma wounds?
Yes, Aeromonas infection and sepsis can occur in patients following trauma, sometimes causing severe myonecrosis, which is muscle tissue death, patients with wounds contaminated by freshwater or seawater, or burn patients who might have environmental exposure to the organism from water or soil are also at significant risk.
What about mortality rates for Aeromonas infections?
They vary quite a bit depending on the type of infection in the patient population, but they can be very high. Reported rates range from around 25% among immunocompromised adults with sepsis, up to over 90% in devastating cases of myonecrosis. And the species Aedocarditis, when causing bacteremia, has been specifically associated with higher 14-day mortality rates compared to other Aeromonas species.
Are there any distinctive skin signs besides necrotizing fasciitis?
Yes, Aeromonas can produce skin lesions called ecthyma gangrenosum. These start as hemorrhagic vesicles, maybe with a rim of redness, that then develop central necrosis, tissue death, and ulceration. What's important is that these lesions look strikingly similar to those sometimes seen in severe Pseudomonas aeruginosa infections. Seeing eczema gangrenosum should definitely make you think of both Pseudomonas and Aeromonas.
Good clinical pearl. Does it cause hospital-acquired infections too?
Yes, it also causes nosocomial infections related to things like catheters, surgical incisions, or even, interestingly, related to the use of medicinal leeches.
Leeches? Why leeches?
Medicinal leeches are sometimes used in reconstructive surgery to help maintain blood flow in tissue flaps. It turns out that Aeromonas species live symbiotically in the gut of these leeches. So when the leech bites, it can introduce Aeromonas into the patient's tissue, potentially causing infection.
Fascinating and slightly creepy. What other infections can it cause?
Other manifestations mentioned include meningitis, peritonitis, even unrelated to cirrhosis, pneumonia, and ocular infections, eye infections, often related to trauma involving contaminated water or soil.
Okay, treatment for Aeromonas. Given the potential severity and the environmental source, what works?
Generally, Aeromonas species tend to be susceptible to fluoroquinolones, like ciprofloxacin, third and fourth generation cephalosporins, carbapenems, like meropenem, and aminoglycosides, like gentamicin.
So a decent range of options.
Usually, yes. However, resistance to all of those agents has been described. This makes susceptibility testing absolutely critical, especially for serious infections. The reason for this potential resistance is that Aeromonas species are known to produce various lolactomases, including inducible MPC blood lactomases and even carbapenemases, those enzymes that can break down even our most potent carbapenem antibiotics. So you really need to test susceptibility to guide therapy effectively.
And because of the leech connection.
Right. As a specific prophylaxis note, antibiotic prophylaxis, often with ciprofloxacin, is generally indicated when medicinal leeches are being used therapeutically, precisely to prevent these Aeromonas infections originating from the leech gut.
Makes sense. Okay, next group, Elizabethkingia and Chrysobacterium species. These names sound a bit unusual.
They do. Let's start with Elizabethkingia meningoseptica. This organism was actually formerly known as Chrysobacterium meningosepticum, so the name changed, which can be confusing. It's a non-fastidious, aerobic, non-fermentative, gram-negative bacillus. Unlike some others we've discussed, it's not particularly picky about its growth requirements.
And it's mainly a hospital problem.
Yes, it's recognized as an important cause of nosocomial infections, those acquired in healthcare settings. It's been implicated in outbreaks, often traced back to contaminated fluids or environmental sources within the hospital, like sinks, contaminated disinfectants, or even aerosolized antibiotics. It can also cause sporadic infections related to indwelling medical devices, like central lines or feeding tubes.
Where have most reports come from?
Interestingly, most published reports on Elizabethkingia meningoseptica have originated from Asia, particularly Taiwan. There was also a report from South Korea describing infections associated with mechanical ventilation that had a very high case fatality rate, raising significant concern in ICU settings.
And it can be hard to get rid of in hospitals.
Apparently so. Outbreaks due to this organism have often persisted until really extensive environmental cleaning and decontamination of equipment has been performed. It highlights its tenacity in hospital environments and the absolute need for rigorous infection control measures.
Who tends to get infected?
Nosocomial E. meningoseptica infection usually involves vulnerable patient populations. Preterm neonates are particularly susceptible, as are patients with underlying immunosuppression, like those with cancer or diabetes, or patients who have been exposed to broad-spectrum antibiotics while in intensive care units.
And what kinds of infections does it cause? The name meningoseptica sounds ominous.
It does. And indeed, it has been reported to cause meningitis, primarily in neonates, but it also causes pneumonia, sepsis, endocarditis, bacteremia, eye infections, and soft tissue infections. So, quite a range.
And you mentioned the name changed. Are there other related species emerging?
Yes. Beyond E. meningoseptica, other species of Elizabethkingia are now being recognized as emerging human pathogens, largely thanks to better identification methods like MALDI-TOF mass spectrometry and 16S RNA gene sequencing. In one report mentioned in our source, looking at 86 clinical isolates initially thought to be E. meningoseptic, only about 20% actually were. The majority, almost 60%, turned out to be a different species, Elizabethkingia anopheles.
E. anopheles, where was that mostly found?
In that report, more than 3/4 of the E. anopheles isolates were from the lower respiratory tract, and about 9% were from blood cultures. This really highlights the evolving landscape of this genus and the importance of accurate species identification.
Was E. anopheles linked to severe disease?
Yes. A subsequent U.S. study looked at 11 patients specifically with E. anopheles infection. All of them had bloodstream infections. These patients typically had underlying comorbidities and recent healthcare exposure, and there was a concerning mortality rate of 18.2% in that small series. This signals that other Elizabethkingia species, not just meningoseptica, are clinically relevant and capable of causing severe systemic infections, particularly in vulnerable hospitalized patients.
What about the related genus Chrysobacterium?
Right, Chrysobacterium indologens is another related organism mentioned. It has been known to cause bacteremia, sepsis, peritonitis, meningitis, and pneumonia. again, typically in immunocompromised patients, often those with indwelling medical devices. Mortality rates have been reported as high as 50% in some series, but as the text notes, it's often difficult to tease out whether this poor prognosis is primarily related to the severity of the patient's underlying illnesses or to the multi-drug resistant phenotype that Chrysobacterium often exhibits.
Multi-drug resistant. So treatment is tricky for both Elizabethkingia and Chrysobacterium.
Very tricky. These organisms are often intrinsically resistant to many antibiotics we'd normally use for gram-negatives. They're often susceptible in vitro in the lab to fluoroquinolones, minocycline, tigecycline, and rifampin. They might also show susceptibility to some actin-malactamase inhibitor combinations, like piperacillin tazobactam.
But the alarming trend.
The alarming trend is that multi-drug resistant isolates are definitely increasing. These resistant strains can possess nasty enzymes like extended spectrum morlactamases, ESBLs, which break down most penicillins and cephalosporins, and even metallolactamases, MBLs, which can confer resistance to carbapenems, our last resort lactomes. This leaves very few treatment options.
What about drugs usually used for gram-positives, like vancomycin?
That's an interesting point. In vitro susceptibility testing sometimes indicates activity of agents typically used against gram-positive bacteria, like vancomycin, against Elizabethkingia or Chrysobacterium. However, the clinical reliability of using these agents in patients is unclear and generally not recommended based on lab testing alone. Given this complexity and resistance, combination antibiotic therapy might be necessary for successful treatment, and susceptibility testing, performed by a lab experienced with these organisms, remains absolutely essential to guide the choice of optimal agents.
Definitely sounds like a job for infectious disease specialists. Okay, let's touch upon Rhizobium radiobacter. This one also had a name change, right?
Yes, it was formerly known as Agrobacterium radiobacter. This organism is usually associated with infection specifically in the presence of medical devices. We're talking about intravascular catheter-related bloodstream infections, prosthetic joint infections, prosthetic valve endocarditis, and peritonitis related to peritoneal dialysis catheters. Cases of endophthalmitis, that infection inside the eye following cataract surgery, have also been described. This strongly suggests an ability to form biofilms on these foreign materials.
And who gets these infections typically?
Most Rhizobium radiobacter infections occur in immunocompromised hosts, especially individuals with cancer or HIV infection. Cases have also been reported in elderly patients who presented with septic shock, watery diarrhea, and acute renal failure.
How treatable is it?
Fortunately, compared to Elizabethkingia, strains of Rhizobium radiobacter are usually susceptible to several antibiotic classes, including fluoroquinolones, third and fourth generation cephalosporins, and carbapenems, as indicated in Table 158.2.2. So there are generally good treatment options available if identified correctly.
Okay, moving to the marine environment now with Shewanella species.
Right, Shewanella species. These are ubiquitous, non-fermentative, gram-negative organisms commonly found in seawater and various marine environments. Human disease is primarily caused by two species, Shewanella putrefaciens and Shewanella algae, with some evidence suggesting that S. algae might be the more virulent species, causing more severe disease.
And given their marine habitat, how do people usually get infected?
Exposure is key. Most infections involve the skin and soft tissue, ranging from relatively mild conditions like impetigo to severe, life-threatening, necrotizing fasciitis. Patients are typically exposed to the organism through contact of bites, maybe from marine animals, open wounds or devitalized tissue with seawater, marine animals themselves, or even contaminated fresh seafood.
So think cuts or scrapes exposed to the ocean or handling seafood.
Exactly. Other infections caused by Shewanella include those involving the lower extremities, like cellulitis or ulcers, osteomyelitis, bone infection, often underlying a chronic wound, biliary tract infections, pneumonia, less common, bacteremia, sepsis, and potentially even chronic otitis media, ear infections.
Can these infections become really severe quickly?
Yes, a fulminant, rapidly progressive course is particularly associated with certain underlying patient conditions. These include cirrhosis, hemochromatosis, an iron overload disorder, diabetes mellitus, malignancy, or other severe underlying debilitating conditions. These comorbidities seem to predispose patients to much more severe outcomes with Shewanella.
Is it often fatal?
It can be.
Yeah.
In one series of cases reported from the island of Martinique, a concerning 13% of Shewanella infections proved fatal.
Yeah.
For treatment, the good news is these organisms are often susceptible to fluoroquinolones, third and fourth generation cephalosporins, lactamase inhibitors, carbapenems, and aminoglycosides. But again, testing is recommended, especially for severe infections.
Okay, next, Chromobacterium violaceum. This one sounds colorful.
It is. Achromobacterium violaceum produces a striking violet-colored pigment, hence the name. It's a facultative anaerobic organism found in soil and water, particularly in tropical or subtropical regions of the world.
And infections happen after exposure to soil or water in those regions.
Yes. After exposure, usually through breaks in the skin, it can cause rare but very serious and often fatal skin and soft tissue infections, typically involving the limbs. These can progress rapidly to sepsis. However, it's worth noting, as the text mentions, that several recent reports have suggested a potentially more benign clinical course with lower mortality in some cases, perhaps reflecting earlier diagnosis and better treatment.
But it can be life-threatening, especially in certain patients.
Absolutely. Life-threatening infections with severe sepsis and metastatic abscesses spreading to distant organs like the liver, lungs, or spleen occur most often in patients who have some underlying illness. This is particularly true for children with defective neutrophil function, such as those with chronic granulomatous disease, CGD. Their immune systems struggle to kill the bacteria effectively.
And treatment is complicated by resistance.
Yes, Chromobacterium violaceum is frequently resistant to multiple drugs, including many standard first-line antibiotics like penicillins and cephalosporins. This makes treatment quite challenging. Carbapenems are most often used empirically if this infection is suspected. Fluoroquinolones and trimethoprim sulfamethoxazole can also be active against some strains, but susceptibility testing is crucial given the high likelihood of resistance.
Okay, and finally, just to round out this miscellaneous category, our source briefly acknowledges numerous other noteworthy gram-negative bacteria, just to highlight the sheer diversity out there. Can you list a few?
Sure. It's really just to emphasize the point that the list goes on. Mentioned are things like Achromobacter anthrapi, which is often associated with infections related to central venous catheters and compromised hosts, but can cause other invasive infections too. There's Pseudomonas or zahavatans, formerly Flavomonas, also linked to catheter-related bloodstream infections, particularly in immunocompromised patients. Sphygobacterian species, rare causes of human infection, often in compromised hosts, and they can colonize hospital water systems, respiratory equipment, and lab instruments, making them a potential nosocomial hazard. Then there's Phingomonas possumobilis, found in soil and water, a rare cause of infection in both healthy and immunocompromised people, capable of causing bloodstream infections, respiratory distress, sepsis, and notably having a predilection for bone and soft tissue infections like osteomyelitis and septic arthritis.
It just keeps going.
It does. A different species, Sphingomonas corensis, was associated with a small cluster of hospital-acquired cases traced back to the plumbing system again. Water sources. Ralstonia species can also contaminate water supplies, including hospital water systems, and have been linked to bacteremia, osteomyelitis, pneumonia, and meningitis.
And even more.
And the list in the chapter concludes by mentioning other genera implicated in human infections, including Moraxella species, Bacterial species, various unnamed CDC groups, like CDC group IF, and Olagella erythralis. For details on these rarer organisms, the source advises consulting more specialized subspecialty texts.
Wow. So what does this all really mean when we step back and consider this vast, almost bewildering array of miscellaneous gram-negative bacteria?
I think it means two key things. First, these examples collectively highlight the immense diversity of potential bacterial threats that exist, often lurking quietly in our environment, soil, water, animals, as well as within healthcare settings and on medical devices. Second, and perhaps more importantly for clinical practice, it underscores the absolutely critical importance of diagnostic specificity, knowing exactly which bug you're dealing with, and, as we stressed at the beginning of this section, vigilant in vitro susceptibility testing.
Because without that specific idea, knowing which drugs will actually work,
You're essentially flying blind. Trying to treat infections caused by these often unpredictable and potentially multi-drug resistant organisms without that laboratory guidance is fraught with risk. It emphasizes the need for good microbiology support and careful interpretation of results to guide therapy effectively. Mastering this complexity is essential.
we have truly taken a deep dive today, haven't we? Wow. We've plunged deep into the hidden world of the HACEK group and these other fastidious and miscellaneous gram-negative bacteria. We started with Moraxella, catarrhalis is surprisingly rapid and still evolving resistance to common antibiotics, which really set a precedent for some of the global antimicrobial challenges we face.
And a common bug with uncommon adaptability. And then we moved to the life-threatening, albeit often treatable if caught, endocarditis caused by the HACEK organisms, digging into the specifics of each member.
And we didn't stop there. We explored the diverse infections linked to environmental pathogens like Capnocytophaga and Pasteurella, often acquired from our animal companions. We covered the ubiquitous but sometimes severe miscellaneous organisms like Aeromonas and Shewanella found in water, and the persistent healthcare-associated threats like Elizabethkingia and Achromobacter. We've really uncovered a hidden landscape of microbial challenges that impact us in ways we might not often consider day to day.
It's a complex world out there, microbially speaking.
This deep dive really reinforces several crucial takeaways, things that any elite professional in this field really needs to have mastered. It underscores the vital role of precise identification in the microbiology lab getting the name right. It highlights the absolute need for specialized laboratory techniques to actually grow and detect these often fastidious organisms in the first place. And maybe above all, it emphasizes the critical importance of vigilant, ongoing monitoring of antimicrobial resistance patterns, both locally and globally.
Absolutely. Because what might seem like just obscure details in a dense medical textbook chapter are, in fact, vital pieces of the puzzle. They're essential for understanding and effectively treating complex infections that could affect really anyone, but especially vulnerable populations. Getting these details right makes a huge difference in patient outcomes.
And we've seen so clearly how these organisms connect everything: our environment, soil, water, our pets, our medical devices used in healthcare, and even our very own oral flora. It's a constant, intricate dance between microbes and human health, one that requires our constant attention, our constant learning, and our adaptation.
That deep understanding of their nature, where they come from, the threats they pose, and importantly, how to treat them effectively, especially considering resistance, that's what sets apart the truly informed professional.
Okay, so here's a final provocative thought for you, our listeners, to mull over until our next deep dive. Given the remarkable adaptability we've seen in these organisms, especially the fastidious ones, their proven ability to rapidly acquire and spread antimicrobial resistance mechanisms, and their seemingly ubiquitous presence in our environment, what new, perhaps currently unforeseen, infectious challenges might these hidden bacteria pose to global health in the coming decades? And maybe more importantly, how might medical science encompassing diagnostics, therapeutics, and public health surveillance need to innovate to stay ahead of this ever-evolving microbial frontier?
That's a big question. Definitely something to think about. The microbial world never stands still. Thank you for joining us on this enlightening and hopefully useful journey into these fascinating bacteria.